Good morning. Okay, but still good morning and welcome to the first session of the second day of the 5th Vasco da Gama Forum. Is it the first presenter or? So, because our first presenter is already here for the oral presentation sessions, we will start with Sofia Vale Pereira.
Yes.
And the title is Incidentaloma Squared regarding a case on quaternary prevention.
Faço para... that's already. Do you know, sorry, this doesn't work? I don't know. It's okay. Now I can put it here. So, good morning, and thank you all for being here, and I hope that will not be an accident to your day starting here to hear from you. Okay, I'm going to present a case report knowing incidentaloma squared regarding a case of quaternary prevention. So, this is the contents of my presentation, an introduction, a case description of the case, a little discussion, and the references. So to keep in mind, in our daily practice, we are forced in our daily routine, it's frequent to use the quaternary prevention. So, in order to prevent some cases that is frequent in our daily practice. So, in the overwhelming patient list that we are facing in our daily practice, and also the lack of time per medical appointment, forces us to being like in a trap and falling into some cases that we called incidentalomas, and this was the case that I'm going to present. And if we mention and think in our daily practice on quaternary prevention, we could in some way prevent this kind of situations. So in primary prevention, we treat earlier and potential serious diseases, and we are curious in our clinical investigation. But if we not use our quaternary prevention, and if we not keep that in mind, we're falling into treating known diseases, and we create some alarmism in the patient, and some iatrogenic procedures also could occur, and also create patient stress. And this paints a picture of a disease-mongering process and a sickness phenomena. So this case is about one man, this was the first contact with this family physician. And he went to the doctor to request a report for a new electric wheelchair. He was asymptomatic, but as he was not a frequent patient, we catch like a primary care approach, and we create an opportunistic approach. So we made a complete clinical history and a complete physical examination on a paraplegic with that it was not significant alteration except the low thoracic expansion. And of course, he requests a report, so we must do a physical exam to make a report. So he had a paraplegia, he has tobacco abuse, he has a neurogenic bladder, and I will explain in front that. So with patient capacitation and decision, and after an explanation and informed consent, we ask for blood and urine analysis and an ECG, a thorax X-ray, and a tobacco intervention, and also a rehabilitation support. Is that because it was a primary care approach, and when you use that opportunity to make an improvement on the relation on physician-patient, we create an opportunistic approach in the not-frequent patient, and we may have clues to may lead to a family assessment in the near future with that kind of inquiry. So this is a man, 40 years old. He's a physics professor on a high school and has a doctoral degree in chemistry, and he was divorced. He has habits of tobacco abuse with strong habits, but it's reduction now, and no alcohol. Has a familiar history. He has a father with melanoma diagnosis at 60 years old, and that's diabetes and hypertension, and mother hypertension, also a carcinoma, a thyroid carcinoma, 60 years old, and a breast carcinoma diagnosis at 60. As an occupational history, he has a chemical laboratory exposure due to our labor context. So, as a personal history, he had a vertebral trauma when he was 24 years old with a C6 and C7 fracture that led him in a tetraplegia, and after surgery fixed, he has an upgrade to paraplegia, but in fact he used a wheelchair and had a neurogenic bladder recurrent about this tetraplegia, urine tract infection of repeated urine tract infection. He had an hemorrhoidal disease and a chronic, due to his chronic constipation, but despite of this, he has a certain autonomy for daily routine. So we can here see that this was this first accident. He had cervical fixation about this tetraplegia and endocavitary bladder botox and treatments for hemorrhoidal crisis. This was his medication, and he had no allergies. He belongs to a unitary family. He had one child that he keeps in contact. He's in a higher socioeconomic class, and he has an APGAR familiar and moderate dysfunction due to his relation, and is being a little bit solitary. So when we asked for the first exams with consent, informed consent, he then showed us and appeared in the medical doctor to show his first exams. And we see, we're not expecting this, an incidentaloma. We see on X-ray an oval opacity with 1.6 projection, middle region, and well-defined limits to be studied. And also this kind of alterations on ECG, but not so significant. So besides this, we have to proceed the study. So then we sat together, and we made a thoracic CT scan. And what we find on that, we saw an isolated and nodular lesion with irregular and spiculated contour, and it was unique and spiculated. So beside of this, we have to study that, and we contacted the pneumology department to reference this patient to be studied. At the same time, he also had an anemia because of his constipation and hemorrhoidal disease, but it was oriented. About that, he went to the pulmonology department to make an elective procedure of transthoracic biopsy, but there was the second accident. He had an iatrogenic pneumothorax that resolved with the conservative therapy. And he was expecting for realization this PET CT scan. So this was the second accident. He came to the primary care. He was a little bit anxious about all these thoughts. And after that, the biopsy was inconclusive. So with all that kind of exams, he don't know what he have in his lung. With a higher tobacco exposure and chemical exposure, was a little bit afraid. After that, in the PET scan, that kind of lesion was an irregular contour and it had captation. So another thing that was worried and worrying our patient and also the clinicians that were with that patient. So with that things, we have an histological that was not conclusive, so we had no clear diagnostic direction to this patient. After that, he was proposed to the cardiothoracic department to have an electric procedure with a thoracotomy, and he had an extracoronary biopsy. And then, after that, the histopathological biopsy was diagnosed as a BALT, so a benign condition, a bronchos-associated lymphoid tissue BALT, hyperplasia. So after all these things and all these steps, he had a benign condition. So this kind of BALT tissue is an ectotopic lymphoid tissue, is formed upon inflammation or infection, and it usually is in the lung as a diffuse mode or nodular form, that it was in that case. It's commonly associated with autoimmune disorders or infections. It's acquired antigens in the respiratory airways and initiate local immune response and maintain memory cells in the lungs. Only the diffuse form may progress to multilymphoma. The other forms are benign conditions. So in this situation, this is a struggles in family medicine. We have to balance the decision between probabilities and few leads. And in fact, we had a patient that without complaints, but his post-traumatic experience, his low thoracic expansion and an occupational exposure to tobacco and chemicals. Are we making a defensive medicines or not?
You have 1 more minute, sorry.
It just finished, just the last slide. We have an anxiety, we can imagine the anxiety of this patient during all this episode. And he's already stopped his tobacco, and he was maintaining regular contact with his family physician. Are we creating worried wells or no? We are practicing the best interest for our patient. We are feeding into our uncertainties. So it was a good practice to ask for an X-ray in that clinical context. Should we have stopped earlier? Was it a relevant surgical approach, and the feelings of the fears of the patient? It was important to better diagnose screening techniques to avoid more invasive approach and iatrogenic recurrence. So, just for in case rapidly, in this study, in this number of cases of pulmonary knowledge, only 65 or 23% was benign. And 35% of these never smoke, and 54 were former smokers. And in that kind of nodules, 34 were speculated, and 64 had a captation of PFDB. So I asked to the audience, what did you do in that kind of situation behind this clinical reports? And it was a good approach, or in your opinion? Thank you for your attention.
Thank you so much for this presentation. And you've already introduced the discussion section, so questions from the audience for the speaker?
Okay.
Sorry, I think practice is different in England. Hello, hi, I'm Mehdi. I think, do you often do an initial X-ray on the first visit to a GP?
If we do an X-ray in the first visit, no. Okay. It was an opportunistic, because it was a not frequent patient. So, okay. And he had, in fact, he was asymptomatic, but he had low expansion because he's a wheelchair, and he had no expansion. He had tobacco habits, very hard habits of tobacco, and also chemical exposure of his chemical degree. So behind that facts, we thought, and also thinking about interstitial diseases, or DPOC, but in fact he wasn't symptomatic. But it was our approach. and also because sometimes this kind of patient needed some clinical reports to make fundings to the, how do you say, in Portuguese we say in public health, in order to have incapacity to getting benefits, financial benefits. And we, as a family doctor that doesn't know anything about that patient, we have to have some clinical things to write in a kind of report. So it was like that's our, in fact, and like a line. It was a patient without complaints, but have some risks, and at the end he ended with a lack of a lung, in fact. But sometimes this kind of nodules can be also not a benign situation. So this kind of, this is curious because it's like an incidentaloma that it was very, that's why I put that title, because he had, in fact, very accidents. The first accident, the car accident, and then the fact of incidentaloma in that X-ray, and then he had a pneumothorax, and then the things were not conclusive, the histological procedure, and in fact he had to make a piece of lung out. It was.
Thank you.
Thank you very much. If anyone doesn't have a, okay, burning question.
So thank you first and foremost for your brilliant presentation. My name is Christina. I come from Lithuania. So I just wanted to ask you if you as a GP in your country have a right to refer a patient directly for CT or PET scans. And how does that work?
But we were not the one, we can ask for X-ray and then the CT scan. After that, he was referenced to the secondary, to an hospital and the pneumology department. And behind that step, he was oriented by the pneumology department in the hospital central, and also with us. But in that kind of situation, we always just like support to him to holding that kind of situation, the anxiety and all that things, because the lung nodule was after that also always oriented in the secondary approach, in the secondary hospital, not in the primary care.
Okay, thank you very much. I will invite the next speaker.
Okay.
Ana Claudia Monteiro Pereira, right? And the title is Importance of Domiciliary Visits for Polypathological Patients. You have 10 minutes.
Just a second, please, sorry. Oh, may I start?
Yes.
Hello, my name is Ana and I'm from Gama, near Lisbon. I work in Travessa da Saúde, and today I'm going to talk about the importance of domiciliary visits for polypathological patients. They are a great majority of the ones we encounter in our everyday practice. First, I have nothing to disclose, and I was given permission for the presentation of all the images and information present. Nowadays, more and more people suffer not only from one pathology, but from several ones, which collectively contribute to their morbidity. Also, reach a time where people could live longer, but not as they wish to live, or with dignified quality. As family doctors, in our everyday routine, we must look attentive and seek better strategies to help them live their lives with quality and fulfillment of their wishes, trying to understand them, their families, and environment and agenda, balancing between what could be the best clinical approach and the outcome and desire of our patients. To exemplify that, I bring you the case of this 80-year-old man. He's retired from his own successful fruit company, married, and only in the late years partially dependent on the activities of the daily living. Since his birth, even with a syndromatic biotype and a severe scoliosis, he proved himself that he could be a self-made man and successful in every aspect of his life. He lives with his wife and, if needed, as the support of his younger granddaughter, who live in the same building. We can note that other members of this family also have their share of clinical problems. So, even with a congenital disease that at first sight could be limited, only at his 60s, it becomes severe enough to conditionate respiratory failure and his mobility capacity due to pain. Meanwhile, other problems in multiple systems arrive, as you can see. The pharmaceutic bills grows and grows with the necessity of taking more than 11 different pills per day. In the simple eye, a severe scoliosis is not the best image, and here is not so good, sorry. Here with a hematoma from a fall. Every 6-12 months, it does a pulmonary function test that are being stable over the years, or with a slight improvement. During the evaluation of his lungs, on the window appeared an adrenal mass that he refused surgery. 2 years later, that mass grew and a calcified micronodule appeared. That adrenal mass, along with hypertension and increased adrenal hormones, compatible with pheochromocytoma, and he had no other risk factors that could justify them. In 2014, as an hypertension complication, he had a stroke that left him with atony of the left arm. He started to be always at home and became depressed. Within the many goes to the hospital, it was discovered some cardiac problems with no clinical repercussion. Also, he maintains a gastroenterology follow-up every 6 months for a diverticulosis and a stable Crohn's disease. Annual follow-up in neurology for his BHPH, and even with a negative genetic test, he has all the clinical features for neurofibromatosis type 2. But you can look at him only through this disease. We are family doctors, we are not surgeons. So when you see a patient like him, it's important not to see only his reports, the exams and symptoms, but we need to understand where he lives, with whom, and who can help him when needed, and many other questions. So me and my tutor decided to pay him a visit, trying to see more about it. And we became aware of how difficult it had been for him to leave his house and come down 54 degrees just to see us or any other doctors. He had a big balcony where sometimes he walks, and also brought a carpet runner where you can exercise at least 30 minutes a day, more than some of us here. For the times when oxygen could be needed, he adapts a ventilator. It was through the domiciliary visit, when you reach him in his own environment, that we are able to find these main difficulties, different from those purely clinical, and that we could perceive his past, the way he faced and thought for all his life, and alternatives he found to feel good and live with quality. It helped me and my tutor to look on our community resources, other ways to simplify his life. For example, we find and connect with social services, so we can be able to park near the healthcare service and similar ones. We also ask for domiciliary physiotherapy and start using telemedicine to share information and updates. In this case, we can talk about morbidity. For example, he has Crohn's disease, he has a congenital scoliosis, and also hypoacusia. Also, we talk about comorbidity, when he has a scoliosis that conditionates respiratory problems and a chronic pain. Is pheochromocytoma that leads to hypertension and then to a stroke. So they are all equally complex and have similar potential for destabilization, difficulties in management, in mutual interrelationships. Multimorbidity is increasing and our focus should be on the patient as a whole. And also, we should give we should prioritize how their self-management. In Portugal, multimorbidity was found to be of common occurrence and increasing over the last few years, so as its costs. But why did I choose to bring this man and his history and not one of the others that we see every day with multimorbidity? In what it differs from the others? First, he never gave up from a normal life, even being born with a severe malformation. And it won't be now that he should lose control of how he will deal with his health. As family doctor, our goal is to focus on our patient expressed needs and share with them the decisions concerning his health and future. When you meet a patient with these features, it becomes crucial to know not only his clinical, but also his biopsychosocial environment. We love this word. Home visits are a good way to achieve this involvement, so important in family medicine. The follow-up of a patient with polypathology and multimorbidity has its own characteristics, and often the patient's agenda differs from ours. Therefore, it's key not only to use the available tools to evaluate family and social risk, but also to assess patient satisfaction. For all of you, I ask you to think about that patient that you only know by his pathology, and when you go home, pay him a visit, okay? Many thanks, and any questions?
Thank you. You have 2 more minutes, so if you want to add something more. If not, we can go for questions from the audience.
Hi.
Hi again. Thank you for your presentation. I wanted to ask you, it is a very great idea to pay visits to our patients at home. But how does that work in Portugal? How do you get funding for visits? Or is it funded as part of your job to do home visits? Because, for example, where I come from, home visits are only paid by the government for those people who are in, let's say, very, very bad conditions. So all the rest are kind of forced to come visit us in our clinics. So how does that work? Maybe you would like to elaborate. Thank you.
Okay. In Portugal, our healthcare services in primary care are divided in 3 types, and it depends on each healthcare service you work. We work in a USF Model B, and for that we are paid to pay them the visits. People get, not as interns, but the real specialists are paid for that. In other centers, they have their own transportation, and they then can go there. If a patient asks you to go there, you go. And in this case, you just go there, ask him if they are able to do it, and they say yes. That's fine. Ah, okay.
It's also what she said, and also just to add up, there are some clinics where, if you want, you can have a time period in your schedule just for home visits as well. We have a fixed salary at the end of the month. So in some units, you get 30 euro for visiting a patient. That's what you get at the end of the month. And the other ones is the same schedule, the same funding as all the others. Either way, it's about a little bit about your own goodwill, and many times you go to the patient's home because you feel bad for them, and they're your patients, and you have to go there.
Hello. For domiciliary visits, there are special criteria for all kind of these visits. So we all have that room in our agenda to do it. Usually 1 hour per week. So, but we have to follow that criteria. People that are not able to walk, or if it's a big danger for them to leave home. But just in answer to your question, that 30 euros that are paid for each visit, domiciliary visit, if you leave your office, you do it on your account. Use your car. If you have an accident, it's on your own risk because it's outside. It's paid for it. So I don't think that 30 euros compensates that, but it's a kind of consultation that is a habit for the family physician here in Portugal. I think that's the main thing, that every family doctor should be able to leave the comfort of the office and go in direction to the patient needs. I think that's the most important thing for us to think.
Anyone, any other question?
Not a question, but a comment. Yesterday, I attended a workshop in which the Brave New World workshop.
I also talk.
Exactly, and your presentation links very well with some of the conclusions there, that maybe we need more individual care for our patients and to allow more time for our patients.
Yeah.
And,
And sometimes with this patient in particular, we only are able to do the call and use his wife when she comes to visit us. It's not the same as telemedicine, but because they are old and not so used to use technology, and it's difficult. But I talk with their grand doctor by email if necessary, and she can give me the exams and so on. But I think it's important that everybody should be aware of the importance of telemedicine and the things that we can learn and new initiatives that you can apply if you don't have time or people live far away from here. And I think it's important. It's not important the age of the patient or where does he live. It's easier.
thank you so much.
Thanks.
I will invite the next presenter, Eduardo Cerdeira. Eduarda, sorry, I'm sorry. With 2 cases of not so innocent back pain.
Hi, good morning, everyone. My name is Eduarda Cerdeira, and I was infected myself with Vasco da Gama virus as I did exchange in Madrid 1 year ago. 2 years ago, actually, 2016. I'm here to present you 2 cases of not so innocent back pain. Actually, I'm finishing my residency in this clinic, USF São João do Porto, which is primary care health center that works on the national health system. We have almost 17,000 patients inscribed, and me and my tutor, we share a list of about 1,900 patients. I bring you this because back pain is, without a doubt, one of the most common reasons for medical consultations. And in the primary care setting, most of our patients will have a non-specific back pain. And most of them, actually, they will improve over a few weeks with conservative treatment or even self-care, many times with painkillers and some rest. That's the majority of our cases. But in less than 1%, they will have a serious systemic etiology. And of course, in the consultation, we have to be able to discharge serious causes for back pain, like cauda-equina, metastatic cancer, spinal infection. But actually, these cases, they are rare, and almost all of them, they have risk factors and also symptoms that make we have serious clinical suspicion. And nearly all guidelines on back pain, and we have lots of guidelines on this theme, they stress the importance of red flags that are positive answers to key questions about medical history that indicate the possibility of serious underlying condition. For instance, some red flags, advanced age, smoking habits, personal history of cancer, and so on. Spoiler alert, I bring you 2 cases and they die. They die really fast. The first one is a female. She was 64 years old, Caucasian, married, working as an accountant. Just history of high cholesterol, no other pathologies known. Family history with no relevant problems, and she had all the cancer screenings updated. And she was only medicated with rosuvastatin. And she came to my consultation on April 4th with a mechanical diffuse middle back pain that was ongoing for 2 weeks and with some muscle contracture associated. I did the physical exam, no signs of radiculopathy, no general symptoms, like she wasn't losing weight or anything, and I diagnosed common back pain, and I prescribed painkillers and some rest. And then she came again to the clinic, not only to me, but to other doctors, to my tutor and to other specialists. And she said the pain was not getting as better as she was expecting with the medication. And it was difficult, as I saw in the records, to understand if she really had criteria for night pain, because she said, I mean, I don't wake up with pain. Actually, I'm so worried that I don't even, I'm having some insomnia. So yes, it was in the night period, but when she was moving with mechanical characteristics. With this, we talked about the case, and my tutor said, let's prescribe a CT scan. And the result was just vertebral hemangioma, benign lesion in a thoracic vertebra. And considering prescribed medication, she was on tramadol, and then we also went to the next step, to tapentadol, to opioid. And she was visibly tired of this, but the CT was normal. At least didn't have any sign of cancer. And then on May the 3rd, she had sudden lower limbar paraparesis, and so she went directly to the emergency room, no evidence of stroke, and they diagnosed the lymphoma. Let me tell you, the CT she had, it was a few days ago, and no signs of lymphoma. And, and on May the 3rd, suddenly, a big lymphoma, it was actually mantle cell. And so she was admitted in hematology, and she died really quickly on May the 7th. And I got really upset about this situation. As you can imagine, I started prescribing more CT scans to my patients with back pain, but it was difficult for me because she had the exam and still she didn't have the right diagnosis on time. And on July the 5th, a male, 58 years old, Caucasian truck driver, just history of high cholesterol, a simple adenoma on his colon that was removed, and seafood allergy, nothing else. And he came to the consultation with a lumbago going for 2 weeks. No pain relief with oral diclofenac, he tried at home. He had nocturnal back pain, this is a big red flag, with pain intensity 4 out of 10, worsening with movement, and on physical exam, again, no signs of radiculopathy, he didn't have pale mucosa, he wasn't losing weight, and he was prescribed medication. And this time, I asked my tutor, what do you think we should do with this patient? Every time I was getting a patient with back pain, I was asking my tutor. And he said, okay, let's start with X-ray and then we see, considering the Portuguese guidelines. And we can talk about it in this discussion. So he did the X-ray, no lytic lesions. X-ray is good for that, but he had no lytic lesions. Just arthrosis, and the pain was now irradiating to lower limbs. So of course he had criteria for CT that we prescribed. And on July the 17th, he went to a clinic, to a private clinic to do the CT. He did the scan. Okay, this is not written there, I'm just telling you the story. He did the CT in the private clinic, and he was feeling so bad while he was doing the CT that his wife took him to the central hospital that is just next to the a big central hospital in Porto. So he went to the hospital, the doctor, the specialist, observed him and said, this is common back pain, you had the CT, wait for the report. You did it right now in the private clinic, so let's not irradiate you more. And just take some medication and we will see. And he couldn't wait for the report of the CT. His daughter is a nurse in a hospital in Gaia, and she said, "Father, you are too sick." She took him immediately to another hospital in Gaia, and she asked for the report to come quicker. And just in a few days, this man was with hemolytic anemia. He was admitted in internal medicine. They got the report of the CT. He had lytic lesions on the CT, cancer of a non-primary origin, a man that never smoked, didn't have personal history of cancer, no family history of cancer. He died at the hospital, most likely a gastric carcinoma with bone metastases. And I wonder, what could we have done differently regarding diagnosis? 2 patients in a row, what could we have done differently? And I turned myself to evidence-based medicine. I studied. And I found a Cochrane review that posted that most red flags, they have insufficient evidence to provide recommendations regarding their diagnostic accuracy or usefulness for detecting spinal malignancy. This criteria that we use, red flags, it's really useful for a lot of problems, but in back pain we need to be more criterious. Particularly in low back pain, many times just one single red flag sometimes isn't helpful to decide if we need to ask for more accurate imaging or no. And another review on pain stated that the origin and the diagnostic accuracy of many red flags endorsed in guidelines are unclear. Actually, just history of malignancy or strong clinical suspicion. These are the only criteria with empirical evidence of acceptable high diagnostic accuracy. So, in which patients should we do imaging? In those with neurologic deficits, clinical suspicion of spinal infection, cancer or risk factors for cancer. Sometimes the utility of imaging is limited. In Portugal, a family doctor can prescribe X-ray or CT. If you need MRI, you need to referral. And cancer or risk factors for cancer, these risk factors are, none of my patients didn't have any of these risk factors. As I told you, we have our own national guidelines. This idea of red flags to understand which patient should do more advanced imaging maybe is not suitable for these cases. The most important thing is our clinical suspicion, observe, touch, understand your patient. Thank you so much. By 3 methods we may learn wisdom. First by reflection, which is the noblest, second by imitation, which is the easiest, and third by experience, which is the bitterest, and these 2 cases were particularly bitter for me. Thank you so much.
Thank you so much for this really good presentation and interesting cases.
Thank you.
If we have any questions from the audience? I would ask. Oh.
Yeah. Hello, thank you for your presentation. I work in England, and from personal experience, usually if we have new back pain in anyone over 50, we get a bit more cautious. Again, there are no clear guidelines, but they say new back pain over 50. I personally and my supervisors tend to do a blood test. We might do a full blood count and look for inflammatory markers. Again, I don't think in some of these cases we would have picked anything up, but that's an extra just precaution we take in someone who's a bit older.
That's a great question. I went really deeply on the records. They had blood analysis because they had high cholesterol. Yeah. So they were doing blood analysis every year. And
so annual bloods and
yeah, like a few months ago, no anemia, no any other suspicion. And the truck driver, he had that risk factor for lumbago. I mean, truck drivers spend so many hours sitting. And if I may, I can actually use this time of discussion to read you a bit of the national guideline. That can be discussed. The clinical care is personalized, is individual, okay? We just don't do guidelines. We have to see the patient. But the guideline states that in order to prescribe CT, in case of thoracic pain, we just ask for CT in case of radiculopathy or suspicion of fracture. And in lumbalgia, when there is radicular deficits, when it's persistent superior to 4 weeks, when there is suspicion of neoplasia superior to 4 weeks in individuals over 50 years old, but with 4 weeks of pain. We have to, in general, we wait 4 weeks to ask for CT.
Okay, thank you.
Thank you for the question. Any other questions? You said in the first case that after the end result, which the patient dying and you feeling really bad about it, you tended to do more CTs, to ask for CTs for every patient.
No, yes.
No, as a joke, but don't you feel that guidelines help us manage this uncertainty better? That
guidelines are wonderful. At least for me, I rely on evidence-based medicine to do my job every day. And that's not what I'm criticizing. Actually, I'm just frustrated because I feel I did what is supposed to do. And as doctors, and as a young doctor, I have to learn that even when I do what's written on guidelines, my patients eventually die. And I wanted to share this with you. And yes, I prescribed more CTs, and that's not very rational. But that's also the role of my tutor to help me in this learning process. And maybe I will try to seek Balint group.
and also for us to raise questions when we think that a guideline needs reviewing, or that something's not wrong, or that something's wrong there. So, thank you very much. I will invite the next speaker, who I hope is in the room, Sara Coelho. Yes? Okay. And the title is Piriformis Syndrome, a form of non-discogenic sciatica. I will use this time to present myself, because I realized I didn't present myself in the beginning of the session. So I'm Raluca Zoițanu. I'm a GP in Romania, and I'm also a member of the Vasco da Gama movement executive and the representative of the Vasco da Gama movement in the WONCA Europe executive. And I'd like to also acknowledge the presence in the room of the past president of the WONCA Europe organization, Professor Job Metzemakers from the Netherlands, who is a good friend of VDGM and helping us in every forum. Okay, it wouldn't be a conference without some small technical problems.
Maybe if the next speaker is here while we find her presentation.
Okay, yeah. Okay. Mm-hmm. So perhaps we would go to the next speaker, Natalia Rodriguez, if she's in the room. And we hope her presentation works. To make our friends who are organizing the Krakow pre-conference happy, I will use this time also to plug the pre-conference in May in Krakow, where you can also, no, for the pre-conference you can't submit that abstracts, but for the conference, for the main conference, which is the WONCA Europe, big European GP conference, you can send in your work and you can be seen by an even larger audience than here. So we await your, actually, the abstracts submission deadline for Krakow passed, but in the future, just so you know that there are WONCA Europe conferences, yes, every year. Next year in Bratislava, so we await for your work there as well. It's a bit early morning for me, so my brain is not. And our image coordinator, Christina, is asking me to remind everyone to please follow our Vasco da Gama Instagram account, Facebook, and Twitter, so you are reminded of all the announcements we are making. Oh, and technology saved us.
Okay.
So, Natalia?
Good morning. Sorry about this problem. My name is Natalina Rodrigues. I'm the resident family doctor in Portugal, and I'll start my presentation. So, this case report is about a female, 37 years old, married and resident in Coimbra, Portugal. She has completed a high school education and she works as a store employee. There are no relevant changes in her eating habits, immunization, or allergies. On anthropometric data, she only is a little overweight. There are no relevant changes in gynecological history, and her usual medication is Advil, low-flenzapate, and venlafaxine. About her previous pathologies, she had a depressive disorder and chronic sinusitis. About her family evaluation, she belongs to a nuclear family with a traditional marital relationship. She belongs to a Duval's family life cycle at stage 1 and to a medium A class of Grapher scale. The family APGAR reveals a highly functional family. So this is the genogram about my patient, and this is the psychofigure of Mitchell that shows a good relationship between the couple and a conflicting relationship with the mother-in-law. So the story begins in April of 2010, when she went to her physician to perform preconceptional study. In June, she went to show the preconceptional study performed. Blood tests and cervical screening were okay. So in this consultation, it was prescribed folic acid supplementation. In March of 2011, she went to a consultation because she was having difficulty getting pregnant, and her husband has Crohn's disease. So it was requested infertility blood test and gynecological ultrasonography. In April, she came with the results of the blood test and auxiliary diagnostic exams. So the gynecological ultrasonography showed sample cysts in the ovaries, and the prolactin level test increased. Then she was referred to infertility clinic. She started to be followed at an infertility clinic from June to September, and she performed blood tests and hysteroscopy, and her husband performed semen analysis. In November, she shared clinical information about unilateral salpingitis, and her husband presents hypomotility of the spermatozoa, so the couple were indicated to in vitro fertilization. So in April of 2012, she came with urinary complaints and showed elevated anxiety levels. In this consultation, she started a sick leave. She performed insemination in the 2nd of May, and it failed. She said, I need help. She had complaints of tremors, insomnia, and fainting episodes. She was diagnosed with depressive disorder, and it was prescribed escitalopram and trazodone. For 4 months, she had a recurrent agudization of depressive and anxious disorder, and many sick leaves were renovated. In October of 2014, she brought information from the emergency department. The neurologist requested routine EEG and referral for consultation. She was going to perform new fertility treatment, and it was requested in this consultation, the consultation of neurology and psychiatry, and increased the dose of escitalopram. Another sick leave were renovated. In March of 2015, she was under medication for fertility. And in this consultation, she had increased anxiety and panic attacks. She had problems at the workplace, and in this context, she was referred to the emergency service. In April, she underwent embryo insemination. She performed a pregnancy test that day that was negative. Now she says, I need more days to recharge. She refers a sense of pressure in her chest, panic attacks, sadness, and emotional lability. She said also, it is increasingly difficult to leave my house. From February to September of 2016, she came several times to primary health care by multiple complaints such as atypical precordial chest pain, tiredness, dizziness, nausea, and blurred vision. During this follow-up, she performed multiple diagnosis tests. Still in September, she came with the results of auxiliary diagnostic exams compatible with the diagnosis of thyroiditis. In 2017, she went to her family doctor with recurrent complaints of pelvic pain and migratory arthralgia of the large joints. The analytical study revealed increased inflammatory parameters, namely erythrocyte sedimentation rate and C-reactive protein. She was then referred to an autoimmune disease specialist because of reactive arthritis suspicion. In November, she went 3 times to emergency department for seizures, dissociative crises, and she had several medical appointments to the family physician with somatic complaint and crisis in the workplace. She started psychotherapy at the request of her husband. This case report shows how infertility generates a range of feelings such as distress, depression, panic disorder, or social exclusion. However, even the treatment of infertility can be associated with some important symptoms. This clinical condition decreases the quality of life and directly affects relationships in homes, workplace, and social environments. So, thank you.
Thank you for this, for your presentation and excellent timekeeping. I would take questions from the room for our speaker.
Hello, thank you for your presentation. I listened to the past medical history of the patient. Were there any indications that she suffered from depression or anxiety in the past? I think at the time of presentation she was 30s.
Yes, in the first.
Yeah. Because was she 36 years old? I think that's what I remember.
See, she's
37
years old.
Yeah.
And as past the list of problems at the past, in the moment it was start and she want get pregnant, she don't have the depressive disorder, but as an incident disorder that we valorized. And this. In this case, the problematic is she wants to getting pregnant, she can't, and this psychological problem that she has previously increased. And have an impact, great impact in the family, in the workplace, because is much time that she is not at work. Sometimes in the couple, because her husband asks to psychotherapy to her in the last year. So it's many years that this problem continues.
Do you know how bad the previous depression was? Did she need medication?
I don't have any evidence. I searched, but it was in this time that she belongs to another family doctor. And then don't have electronic and physical process.
Sure.
And sometimes she is followed in to a private psychiatry, and it's difficult to have any registers.
Okay. Thank you.
Okay.
Thank you very much. I will invite the previous and next speaker, Sara Coelho. I hope I'm saying your name right. And you will say the title.
Hello again. Good morning. My name is Sara. I came from Coimbra, a city in Portugal. And I will talk, first I will talk about this syndrome, the piriformis syndrome, which is a form of non-discogenic sciatica, and then I will present a clinical case, which is a small. The piriformis syndrome is a neuromuscular disorder causing sciatica. It's characterized by neural compression through or around the piriformis muscle. It may account for 0.3 to 6% of all cases of sciatica and low back pain worldwide, or to 6 to 8% in the USA, according to another study. So, to understand the piriformis, it is in close relation with the anatomy of the gluteal region. So the piriformis muscle is located in the gluteal region. And as you can see, it originates from the anterior face of the sacrum and the hip bone, and it runs outwards and downwards and exits through the great sciatic notch, here in close relation with the sciatic nerve. And it inserts on the superior great trochanter of the femur. Regarding function, it is an external rotator and an abductor of the hip. Its proximity with nerve structures of the sacral plexus explains why there is a nerve irritation and or compression due to dysfunction of the muscle, and this can be caused by several mechanisms such as spasm, contracture, hypertrophy, inflammation, trauma, but in most of the cases it is related with overuse injury. In order to understand the lesional mechanism, it's important to integrate the biomechanics of the gait cycle or the gait pattern. So the march is divided into two phases, the stance phase and the swing phase. So the stance phase is subdivided into three periods, the initial contact, the mid-stance, and the propulsion. And then we have the swing phase with elevation of the ground foot. In the first phase, in the initial context, we may not be aware of that, but we perform a slight internal rotation of the hip. So the piriformis muscle, as you remember, he is an external rotator. So as long as we do this slight internal rotation, the piriformis muscle distends, and since it is an antagonist muscle, it responds with a reflex contraction. In the next stage, where the opposing foot is in the swing phase, and the load is supported only by one foot, so it's a single support phase, we have a second moment of contraction of the piriformis muscle. So this dual contraction pattern can be exacerbated by any gait asymmetry with altered forces, and so the load that we require to the piriformis muscle can be exaggerated. And the most frequent mechanism is lesion or trauma of the piriformis muscle, but it can also be due to relative weakness of the abductor muscles, or even in some cases the mechanism is unknown. It classically presents as a sciatica, causing pain in the gluteal region or the lumbar region that radiates along the lower limb. Just like classic sciatica, it worsens with gait, running, squatting, and sitting, and the intensity varies during the day with the symptomatic periods. At physical examination, there are no neurological deficits, and the straight leg raise test, the so-called Lasek sign, is usually negative. There is some tenderness in the piriformis muscle, and to locate the piriformis muscle, you can imagine a midpoint between the sacrum and the superior trochanter of the femur, and to press the surrounding area and look for this tenderness, always comparing with the other side. Also, there are some maneuvers that we perform to search for this syndrome with two types of mobilization. We have the passive mobilization maneuvers, in which the patient shouldn't contract any of the muscles, and we actually perform is the distension of the piriformis muscle. We have some active or resisted mobilization maneuvers, and all of them can help us to enlighten the diagnosis. So I will talk later about the ones I performed in the clinical case, and if you want, at the end of the presentation, I can show you and explain you the other maneuvers. They are not complex. So about the diagnosis, there are few validated and standardized diagnostic tests. So it is often difficult, is based on clinical features, and it is one of exclusion. So it requires a high level of suspicion, especially when sciatica occurs without low back pain and without Lasek sign. So the complementary exams, as you can imagine, are mostly useful in excluding other conditions rather than in helping to establish this diagnosis. About the treatment, there is no gold standard, and they are widely used, both analgesic and anti-inflammatories, and also physical therapy with stretching and relaxation exercises. These measures also can act as a clinical trial and to support the diagnosis we just made. In refractory cases, one can use botulinum toxin injection or even surgery. Finally, the clinical case, a 48-year-old man complaining with pain in the left hip and thigh, irradiating to the distal third of the leg without back pain. It worsens with sitting position and relieves in the cubitus. Improvement with non-steroidal anti-inflammatory drugs and physiotherapy that he had done before, and this had months of evolution. At physical examination, there was a tenderness over the gluteal region, near the piriformis muscle, and the straight leg raise test was negative. I performed two maneuvers. The first is called the FAIR test, and is a passive mobilization maneuver. So it is actually an acronym that stands for flexion, adduction, and internal rotation of the hip, and it's very simple to perform. You just need to pull, I don't know if you can hear me. I'm trying to, can you hear me? Yes, it's quite easy. You just need to pull the patient's knee up and direction to the opposite shoulder. So I'm doing a flexion, an internal rotation, and an adduction. So you just perform that with the patient in a supine position. Another maneuver I did and that I knew by the time was the pace test or the pace sign, and it's done with the patient in the seated position. So again, it's easier to show you. With the patient in seated position, you ask him So you pull both legs outwards, so to do an adduction of both hips against the resistance of both your arms. So he's doing this against resistance. Sorry. So we ordered a CT scan, which was normal, and we tried to treat with NSAIDs, again, regular physical activity with stretches directed to the piriformis muscle, and a new physiotherapy program. After 3 months of follow-up, he came in with a significant improvement of symptoms, and today he has no symptoms at all, so it was a good case. Concluding, the piriformis muscle is a neuropathy, a compressive neuropathy due to compression of the sciatic nerve in the vicinity of the piriformis muscle. It lacks, it lacks validated and standardized diagnostic and therapeutic criteria, so it requires the knowledge of the clinical presentation and suggestive signs. The course is generally favorable. So I think that given the high prevalence of sciatica in primary care, it's important to consider this diagnosis, not only to avoid an exhaustive investigation, but also to properly diagnose this syndrome and establish therapy. Thank you all.
Thank you very much for the presentation, and again, adherence to the time limit. If there are questions or comments?
Hello, thank you for your presentation. I was just wondering, is there any specific type of physical activity we should advise our patients to adopt?
Yes, so this is actually in the physiopathology. It's related with the gait pattern, so everything that implies a gait pattern, which mostly running, so this is also more frequent in athletes that do a lot of running, so you should avoid that type of exercise. There are some good exercises for this patient. Some of them, all the exercises that don't imply that the patient needs to walk. Yeah. So for example, even in the trampoline exercises or the swimming where there's no charge of the body, or even the elliptica. Basically, as long as the patient is not walking or running, that's a good exercise. Regular. It is supposed to be regular, and it shouldn't provoke pain. It should be painless. And after and before the exercises, he should be told to perform the distension of the piriformis muscle. You're welcome.
Thank you. Other questions or comments? I have.
Hello. What was the indication for the CT scan?
Yeah, so actually, I don't have a...
Was it to rule out disc prolapse, for example, or was there some other reason why?
We just weren't satisfied with the evolution of the clinical complaints since he had done already non-steroidal anti-inflammatories and physical therapy, and the complaints are also suggestive of sciatica, and we were searching for that, just to exclude that, not because it was our first diagnostic hint, but because we needed to exclude. So it was more to be assured that the diagnostic wasn't due to other radiculopathies in the lumbar spine.
And the reason CT was decided over an MRI, is it just a matter of access, that primary physicians can only access CTs and not MRIs?
Yes.
Was that the main reason? Yeah.
MRIs are also more expensive, but we don't have we can't prescribe MRIs in our healthcare center. Welcome.
Thank you.
Thank you.
I will invite our last speaker, Marta Barroca, with a presentation about thyroid autoimmunity and postpartum affective disorder.
So, good morning, everyone. I'm going to present a case of thyroid autoimmunity and postpartum affective disorder. Is there a causal relationship or not? So, we know that during pregnancy there is an immunologic tolerance that explains the favorable course of autoimmune diseases like thyroid diseases during pregnancy, and then an exacerbation at the postpartum. So TSH should be tested as soon as pregnancy is confirmed in case of risk factors like history of hypo or hyperthyroidism, thyroid antibody positivity, family history of thyroid dysfunction, maternal age over 30, and others. And when it is between a normal range, we don't need further work up, but when it is low, there is a thyrotoxicosis. So, thyrotoxicosis at the postpartum may have two causes. Postpartum thyroiditis, which affects up to 10% of women and may exist until the 12th month after delivery, and with different presentations like thyrotoxicosis. The major return to normal, to euthyroidism, spontaneously after 1 year. And then we have Graves' disease, which is impossible to distinguish from the thyrotoxicosis phase of a postpartum thyroiditis, unless there is ophthalmopathy or by lab tests showing a positive anti-TSH receptor antibodies. In 80% of cases, there is also an increased ratio between free T3 and T4. And we know that this disease is increased in the postpartum, even when it is in remission. Simultaneously, maternal thyroid autoimmunity is also related to mood disorders and to postpartum depression. And this is because the autoimmune reactions at the thyroid gland increases pro-inflammatory cytokines that alter not just thyroid hormones, but also neurotransmitters and serotonin in the brain. This, with the sleep disturbances, the pain, the trauma of the delivery in a newly mother, also contributes to postpartum depression. So, we have a 34-year-old female from northern Portugal who lives at the southern Portugal. She has a nuclear family with 2 daughters, 5 years and 16 months old at the moment. She's at phase 3 of Duval's life cycle, and she's a philosophy teacher and a real estate agent, mostly with her husband. She's an ex-smoker. She had urinary tract infections and hyperemesis gravidaria in both pregnancies, and she had some anxiety now and then, and a Graves' disease after the first pregnancy, which she's in remission and without therapy since 2014. In her genogram, we may see that there are 2 cases of goiter in her family, and her mother has panic attacks. So, in 2014, she moved to Algarve at the southern Portugal with her family, back then the husband and 1 daughter. Then, in May 2015, she came to our consultation for a preconception consultation because she was trying a second pregnancy. Given the past Graves' disease, we asked for a thyroid function with all the lab tests for preconception, and the thyroid function was normal. 8 months later, she came already pregnant, and we asked for the first thyroid evolution during pregnancy, the TSH, and it was normal. So the pregnancy went on, and she delivered a healthy baby at 13th September 2016. She was breastfeeding, and we asked for another thyroid evolution after delivery in November 2016. She was asymptomatic, and thyroid function was fine. So, 4 months after delivery, she initiated developing symptoms like neck volume increase, irritability, fatigue, palpitations, a great weight loss, hypersudorosis, cramps, tremor, deconcentration, diarrhea. We asked for a thyroid function analysis and ultrasound because we were suspecting of thyrotoxicosis, and the analysis confirmed it. The ultrasound showed also a goiter, and we asked for an urgent endocrinology consultation. In April, she had that consultation, and she started therapy with thiamazole and propranolol. In this time, when the baby girl had 6 months old, she stopped breastfeeding because she went to northern Portugal to teach philosophy. She started working again, but she moved alone. So one month later, at the endocrinology consultation, she had a thyroid re-evolution, and the endocrinologist planned for a CT scan and cytology. The thyroid function showed a decreased FT4, so he added levothyroxine to the therapy, and the positivity of TREB confirmed the relapse of Graves' disease. In June 2017, she came to our consultation complaining of insomnia, marked irritability, sadness, lack of concentration, which had a great impact on her relationship to her husband and daughters. She said she felt incompetent of taking care of the baby daughter. So she stopped working and she moved back to her family, and we initiated escitalopram and clonazepam. 1 month later, for a re-evolution, although the thyroid function was already normalizing with therapy, she started smoking again because she maintained an unstable mood, insomnia, and difficulty to contain her energy. So we found that a little suspicious, and we discussed the case with our psychiatry consultant, and she agreed to add quetiapine at the bedtime and to schedule a psychiatry appointment to evaluate her better. But she missed that appointment in August. In September 2017, she maintained her follow-up with the endocrinologist, and she said she stopped escitalopram and clonazepam and quetiapine by herself because she didn't feel well with those pills. However, she maintained anxiety, also with the typical precordialgia, and she went back to work, this time as a real estate agent with her husband. Her thyroid function was improving, TREB was already normal, and so she reduced thiamazole and levothyroxine and stopped propranolol. This month, she had a re-evaluation with the endocrinologist, so as the thyroid function is already normal, she stopped the therapy. She said she's feeling better, and she's still waiting for that cytology of the thyroid, and she has another appointment in April 2018. However, she didn't return to our consultation since we referred her to psychiatry consultation. Well, with this case, we must remember that in women at risk, we must be alert for the thyroid's autoimmunity disease. We should closely monitor these women and ask for differentiated support whenever it's needed with the endocrinology consultation. At the same time, in this case, there is not a clear causal relationship between these hormonal imbalances and their affective disorder, because in one hand, hyperthyroidism may justify some of her psychological symptoms, but we should expect that them will improve with adequate thyroid therapy, and they didn't at the beginning at least. On the other hand, a psychiatric condition might have been evolving in the past years and was now aggravated by her thyroid status. So an evolution with the psychiatrist would be necessary to try to distinguish these cases. In conclusion, we as family physicians, we work as a liaison with other specialties to contribute to this continuity of care of our patients with early diagnosis, rapid referral, and watchful monitoring. And this work team provides a better care to our patients, and we are really stronger if we work together with other specialties and with other patients. So, thank you.
Thank you very much. We have about 4 more minutes for questions or comments. If anybody wants to start. If not, then I will ask the question. Considering that the patient didn't come to the practice for 6 months and she was a difficult patient, do you have in your guidelines in Portugal any recommendation to contact such patients to check on how they are, or why didn't they come back with the results to the office?
well, we can do as we think it would be more correct. So we should contact her. Yes.
But it's not encouraged or incentivized to do that.
Well, it's our free will, I believe. So we may contact her or not. We were following the endocrinology records, so we know that she's been following up by this condition. But yes, on the other hand, we should contact her to know if she's all right, especially for the psychological condition.
Okay. We don't have this in Romania either. It's just good medical practice.
I don't know that guidelines in Portugal, but I think it's the sensitivity of the family physician that answers to that need.
Thank you. Other questions or comments? Okay, if not, thank you so much for this presentation and for all your presentations and for the audience participation. And we can conclude this session a few minutes before time, before the scheduled time.